This program is brought to you by Emory University.
Good morning. It's a pleasure to introduce our speaker for Grand Rounds, Dr. Michael Gold. Dr. Gold is the Michael Assey Professor of Medicine in the Division of Cardiology at the Medical University of South Carolina. He is well known in our field, and he started as the Chief of Electrophysiology at the University of Maryland from 1991 to 2002. Then he was recruited to be the Chief of Cardiology at MUSC, where he remained Chief for 14 years, which is probably a record in academia. And he was also served as the Medical Director of the Heart and Vascular Center at MUSC and the Associate Dean of Interdisciplinary Clinical Program. Dr. Gold is currently the President of Heart Rhythm Society. He's authored over 250 publications in peer-reviewed journals, and he served as on the editorial board of several important journals such as JACC, AJC, and Heart Rhythm Society. His research interest focuses on pacing in heart failure and defibrillation optimization. And we'll hear from him about CRT state of the art in 2017. Dr. Gold.
Well, thank you for those kind words, Michael. Great to be here. Just one correction. I actually started as a cardiology fellow with Peter Block, who convinced me that I should stay out of the cath lab. That's how I got into EP. Still have fond memories of someone over the speaker being Peter yelling, "Get out of the left main, get out of the left main." But what I'd like to do is go through a little bit of the history, because it's always sort of fun and I think informative to go through history to learn from our mistakes of what happened and how CRT developed, and then we can talk about some of the newer stuff of what's going on now. And we talked today about the epidemic of heart failure, but this epidemic has been going on for a long, long time. And as we're starting to see the increase in heart failure starting in the mid-1980s, people were looking for innovative approaches of what to do. And a seemingly clever but somewhat perplexing mechanistically concept was developed in 1990. And this actually is what first got me interested in the idea of pacing for heart failure. And up until then, even though pacers have been around for 50 years, they were used simply for bradycardia. And this Austrian cardiologist named Margaret Hochleitner did this study where she took a group of patients in Vienna, all with end-stage heart failure in an era before we had great treatments and LVADs and stuff. They were wallowing in the ICU with Swan-Ganz catheters and waiting for heart transplant. And for unclear reasons, she implanted a pacemaker, none of them with any pacemaker indications. And all she did differently was to program the AV delay short at 100 milliseconds rather than a more typical 150 to 200 milliseconds. And what she reported was these unbelievable improvements in patients who their New York Heart Association class got better. Everything got better. It turns out they were unbelievable. Function got better, and these apocryphal stories of patients who were, again, weeks in the ICU, ripping out their swans, walking out of the hospital 2 days later, getting on their bicycle, listening to Mozart on their Walkman, and everything was good. And we got very excited about this, as did several other people. And so when I first left Mass General, went to the University of Maryland, the first project I did was to try to replicate these findings. And we did a little acute hemodynamic study where we found that none of this got better. We did not see hemodynamic improvements in our patients. Clinically, patients weren't getting better. And I was, we were disappointed. So we published this paper, and back then you could publish a paper in JACC with like 8 patients in it because it was so new. And it started a controversy, sort of transatlantic controversy, because we published this first paper saying this didn't work, and she was the one saying this is the future of treatment of heart failure. And I actually got invited 4 times to European meetings over about a 4 or 5 year period, where I was either asked to speak at a symposium with Dr. Hochleitner or to debate her. And she never showed up. So I've never met this person, and interestingly, I know no one who's ever met this person. So Europeans, no one has ever met her. She apparently does truly exist. But after these couple of papers, she's disappeared. And interestingly, we now know that we should not put in pacemakers and program short AV delays. In fact, we need to avoid it. And we very aggressively avoid doing that because subsequently large randomized studies show that we hurt people by pacing the right ventricle all the time. So what was sort of the birth of pacing of heart failure turned out to be completely wrong, but it got everybody stimulated into thinking about that. And about this same time, again in Baltimore, 2 cardiologists, very famous, Michelle Morawski and Morty Mower, who had developed a defibrillator, actually came up with the idea of biventricular pacing. It's very rare that someone hits a home run in their career, let alone 2 of them. But they came and talked to me and said, you know, stop playing around pacing the right ventricle. We should pace both ventricles. So we, the model that we decided to start trying this on was patients undergoing bypass surgery. Because it was very easy, because our surgeons always put epicardial wires on patients at the time. And the surgeon I was working with, we put wires on the right ventricle and on the left ventricle, and did this acute hemodynamic study where we showed that atrial biventricular pacing, which we called it at the time, was good, and hemodynamics seemed to improve. These were not heart failure patients. These were just coronary patients with normal hearts, essentially going through this. We actually put, these were before the days of catheter ablation for most arrhythmias, certainly for VT, we weren't doing it. So we had these epicardial socks that the surgeons would use to do intraoperative stuff, and we could map and we could show that when we paced the right ventricle, the earliest activation shown on top of the left ventricle was along the septum, which you'd expect is where the breakthrough is. When we paced the left ventricle, it was near the apex where our electrode was. And when we paced both, we got simultaneous activation, and we got a more homogeneous activation of the ventricle, which we commented on, but the term CRT was not around at the time, and we certainly did not coin it. But we were sort of excited about this, and I started talking about, you know, this may be a good treatment for heart failure patients because it seems to work. And I was out in the West Coast, actually I was up in New York talking about this originally, and Dan Burkhoff, who's a famous cardiac physiologist, came up to me and said, you know, you shouldn't be talking about developing this new technique because 10 years earlier, you know, in the 80s, you know, we showed in animals that the left ventricle was the best place to pace. And so I was sort of apologetic and thought I should include, you know, Dan's slides. They had done this back in the 80s. And then I was out on the West Coast, and Frank Tyers, who's a well-known cardiac surgeon up in Vancouver, was there, and he then started to yell at me saying, you cardiologists are all the same, don't you know that surgeons discover everything? And in the 70s, we knew that this was the best place to pace, and we were doing these studies in sheep. And again, I had to apologize once again and told them that my subscription to the Journal of Surgical Research had lapsed, and I didn't see that issue. I was sort of getting tired of being sort of embarrassed publicly that I forgot someone else had done something, so we decided to go back into literature. And you can go back as far as Carl Wiggers and see that in 1925, I think, no one has sort of scooped me on this one yet, sort of showed that pacing from the left ventricle was probably the most effective place to pace hemodynamically. And like many things, you know, in medicine, we sort of discover things and then forget about them because we don't know how to apply them or what to do with it. But we've known this for a long time, and we decided to start studying heart failure patients. And we were doing this sort of simultaneously with a group in the Netherlands, in Utrecht, in an era before we had any catheters to do CRT stuff. So it was actually pretty invasive surgery where our surgeon was doing mini thoracotomy, didn't even have thoracoscopy for this, and implanting leads on the left ventricle with single lung ventilation, and fairly intense stuff. And we only got through 4 patients. Again, this is almost 25 years ago now, because it didn't work. All our patients died. Fortunately, none of them from the procedure itself, but no one was getting better. And in Utrecht, they did about 6 or 7 patients, and they had 2 that looked to be dramatic improvements. So we were all scratching our heads. In retrospect, it was pretty simple, but at the time, we couldn't figure out what was going on. And before we truly hurt someone, we thought it was probably time to sort of stop doing this and try to understand better what was going on. And subsequently, the French and others started looking at specifically patients who had left bundle branch block. And none of us, again, early on, thought it's left bundle branch block where this was going to be helping, or at least came up with that concept. And they showed that it was that group that had this dramatic improvement, again, in terms of CWP is wedge pressure in French, and V waves was mitral regurgitation gets better, systolic blood pressure got better, and it sort of resurrected the excitement in this therapy, that there was a group of patients with heart failure where this would be good. And once there looked to be a potential market, that's when industry jumps in and gets rid of us dabblers who were sort of playing around with it and started developing devices to truly pace both ventricles. And the early studies were simply done with biventricular pacemakers, showing that when you implanted these in patients, you got this very profound and sustained improvement in 6-minute hall walk, which is the usual metric of functional capacity in heart failure patients. For those who don't do much heart failure stuff, a 50-meter improvement is greater than you see with any of the drugs that we use in heart failure. So it's really a strong effect. Quality of life improves significantly. I think the important aspect of this, when we try to interpret studies, if we look in white at the control group, you see a dramatic improvement of quality of life in patients who had the device implanted but turned off. So there's a very large placebo effect, which has sort of haunted this whole field, and particularly device-based therapies, because it's often hard to long-term implant devices with sham operations or have them turned off. But still, there was significant further improvement with CRT. And I think one of the most important aspects of what we see is the concept of reverse remodeling, that when CRT is turned on, you see reductions in left ventricular volumes, increases in ejection fraction, and it's probably one of the best surrogate endpoints in terms of long-term response to CRT that I'll talk about. Larger studies done in Europe, now pivotal studies with long-term follow-up, showed that implanting CRT pacemakers into heart failure patients, all of which have an indication for defibrillators, but the Europeans at the time were not using a lot of defibrillators, so they did this study with just CRT pacemakers, could actually save lives simply by putting these in. And then the American study, the big, large, pivotal study was called Companion, which compared CRT pacemakers, CRT pace defibrillators, and medical therapy, showed that the best results was with CRT defibrillators, which is what we standardly use in most of our patients, certainly in the US and in most places. So these were all severe heart failure patients, class 3, class 4 patients. There were more than 6,000 patients who were in clinical trials, randomized clinical trials, and very consistent improvements in quality of life, functional status, exercise capacity, reverse remodeling was present, and reductions in heart failure events and all-cause mortality. A pretty impressive list that we really can't see with virtually any other therapy. And given that, it was logical to extend it, as we do with most things. The first defibrillators were only approved for patients who had suffered 2 or more cardiac arrests. There was no such thing as primary prevention. Some of you are old enough, I barely remember the days where statins were only used following, statins cholesterol control was only used for patients following a myocardial infarction. People were walking around with cholesterols of 300 and 400, and you have to have an MI before you'd be given some, binding resin to be treated, cholestyramine or something. And then we get more and more aggressive and start looking at primary prevention and other therapies. So the same thing happened in the world of CRT. It works in patients with severe heart failure, but do we have to wait for someone to be debilitated and multiple hospitalizations? Why not put it in mild heart failure? And there were 3 studies that were performed. The first one, which you'll see a fair bit of data from, this was one that I was most involved in as a USPI, was the REVERSE study, which was a prospective randomized double-blind study of patients with class 1 or 2 heart failure. And because, again, it was an implanted device that was turned off, the defibrillator function was left on, the FDA would only allow us to follow patients for up to 2 years. It wouldn't allow longer-term follow-up. So the endpoint was a clinical composite response, which was positive. More patients improved and fewer patients worsened with CRT, which was a good result. At the same time, a second study called the MADE-IT CRT study was being done. And this was a study in which patients either got a defibrillator or got a CRT defibrillator, and it was unblinded. So the FDA didn't care how long you followed those patients. So they were followed for a longer period of time. And looking now, rather than over 2 years, over 4 years, if you look at the endpoint of heart failure hospitalizations, you can see, again, very dramatic improvements, even though these patients only had class 1 or 2 heart failure in terms of functional improvement. And then the third study was called the RAFT study, which was a Canadian study. And the Canadians are a very patient group. They decided they're going to wait for 6 years to implant an ICD or a CRT ICD, CRT-D as it's called. And in fact, they could show in class 1 and 2 and class 2 patients here a reduced mortality. So in patients with heart failure who already have an ICD, adding a CRT to that ICD actually saves lives. All of these were patients pre-selected because they at least had prolonged QRS duration and had sinus rhythm. So again, very impressive that the mild heart failure is just as good as a severe heart failure. Again, the Europeans were pushing for CRT pacemakers as a much more economically advantageous approach for this. And in our study, in the REVERSE study, many of the European investigators used CRT pacemakers. The Americans largely used CRT defibrillators. And we actually were able to analyze, while it wasn't randomized, we could show that those patients who got CRT defibrillators had better outcomes, a lower mortality when we followed out to 5 years, which had been sort of a long-term follow-up phase planned for this study. And it sort of makes sense that patients with bad hearts, systolic dysfunction, are both at risk for heart failure and for sudden death. CRT helps reduce the heart failure, and defibrillators help reduce the sudden death, at least as a simple conceptual framework for why a CRT defibrillator would probably be better. And certainly in this country, 80 to 90% of patients get CRT defibrillators, and usually the pacemakers are restricted for either the elderly or patients with other comorbidities where life expectancy may be shorter. Well, interestingly, again, the Europeans were more pro-CRT pacemakers, but the French, who've probably been the most refractory to defibrillators, did a survey within their own French healthcare system of, again, about 1,600 patients is shown here. And they were able to show, even in their experience, that CRT pacemakers probably, while good, over the course of a couple of years, had double the mortality of CRT defibrillators. So I think in general, this is not as controversial an issue anymore. Well, one of the interesting aspects is, why does CRT save lives? Is it just heart failure that it saves lives for? Because the early studies of pacemakers suggested that, in fact, sudden death is reduced with CRT pacemakers, which could be bradycardic, could be other things. And what we looked at was, as a surrogate of sudden death, was looking at appropriate defibrillator therapies, patients who had VT or VF in our therapy, and looked at those who had CRT turned on versus CRT turned off. This is, again, the reverse study, so it was prospective randomized study, and we saw no difference. So CRT was not affecting the amount of VT that we saw in this group of patients, which, when reading the literature at the time, was fairly consistent. And a little bit surprising that why do these patients who get better and have improved EFs and less heart failure, shouldn't they have less VT? And what we speculated was that maybe the group of patients who in fact get better and whose hearts get better would have less VT, and those patients who don't respond to CRT, essentially just being paced all the time and having a 24-hour electrophysiology study waiting to induce an arrhythmia. And in fact, it turned out to be what happened, that if we use, again, the remodeling, which is the important reverse remodeling of what happens with CRT, the standard definition is left ventricular volume decreasing by 15%. Those patients who remodel are, quote, responders to CRT have a dramatic reduction in ventricular arrhythmias, whereas those who don't remodel, non-responders as they're classified, actually have an increase in ventricular arrhythmias. And if you look at the whole group, you get this neutral effect, which appears to happen. Subsequent studies, including the Mayo CRT study, showed exactly the same thing. There's now multiple studies showing that a structural response predicts a reduction in ventricular arrhythmias and sudden death. But not only does it reduce ventricular arrhythmias, but it's a dramatic predictor of survival following CRT. So again, as I mentioned, we went out to 5 years in the reverse study, and what we were able to show with the same pre-specified reverse remodeling endpoint, if a patient remodels, and in this study, the mean age going in was 67 years, the mean ejection fraction was 28% at baseline. If you have a remodeling response, your mortality at 5 years was 7%. Total mortality, all cause, 1.4% per year in a group of patients who were, while their heart failure was relatively mild, were pretty sick patients. So really a remarkable improvement of how these patients do long term if we can get them to remodel. So it's really been the focus of much of the more modern research, which is, again, the concept of non-responders. And it's virtually impossible to write a paper these days in CRT and not mention that the non-responder rate is 30%. It's in every paper you look at. And this has been stable over 15 years of people writing about this. But it's really a misconception in many ways. First of all, we don't know how to define non-responders. Almost every paper has a different definition of non-responders. There are definitions based on whether your New York Heart Association class improves, definitions on whether you've been hospitalized, definitions on your remodeling, and I showed you the 15% reduction. Some people say 10%. Some people use ejection fraction increases. So it's all over the map. And as you can see here, just whether you compare soft functional endpoints, such as New York Heart Association class, or remodeling, you get very different estimates on what our non-responder rate is. And there remains no consensus on this. But I think probably an even more important concept has been recently sort of formulated, which I think is very useful when we think about this. Heart failure is a progressive disease. It's sort of a competition of the EPs trying to put in CRT devices and the heart failure folks trying to put in LVADs, but patients are getting sicker and sicker over time with heart failure. And at some point, they reach some threshold symptomatically that we implant a CRT device. And we know that some patients normalize again. We call them super responders. And that's pretty clear. If you go from an EF of 30% to 60%, no one's going to argue that that's a super responder. Other patients stabilize over time, but we know the natural history of heart failure is that they continue to get worse. And clearly, if we have someone who just stays on that curve and continues to get worse and ends up needing advanced therapy in heart failure, they are a non-responder. But are the patients who are non-progressors who stabilize, we call them non-responders now because their heart function didn't get better or the New York Heart Association class didn't get better. But is that a bad thing? If a patient who's got class 3 heart failure or class 2 heart failure and after 3 years they're doing just as well, most of those patients tend to progress. And clearly there are patients who get worse with this therapy. We can hurt patients. And it's important to acknowledge that and to follow those patients. So how do we identify who the patients are who are going to respond? There have been a number of markers, simple clinical markers. QRS duration has been a very important one. Patients with a longer QRS duration and the cutoffs that are used in clinical studies and in guidelines, and certainly for approval of these devices, around 120 milliseconds. But if we look at those who have a QRS greater than 150, they have the biggest response, very consistent over meta-analyses. If we look at those patients whose QRS is between 120 and 150, you don't see much of response at all. And some have argued that we should move the bar up to 150 milliseconds and not leave it at 120 where it sits now. And in fact, the European guidelines favor very strongly using a higher threshold. Again, we question this a little bit because there's nothing magic about 150 milliseconds. It's a round number. But QRS duration is a continuous variable, and there's nothing physiologic, at least obviously physiologic, that happens at 150 milliseconds. And if we look in a little more detail here in quartiles at the reverse remodeling effect, again, you can see that QRS duration is a potent predictor of response, but you get remodeling at under 150 milliseconds. Is that amount of remodeling enough to benefit the patients? It's not always clear, but it's not a threshold phenomenon. It's a continuous phenomenon. And similarly, patients, this is from the MADED CRT study, suggested that it was only left bundle branch block, shown on the left, who benefited from this therapy. If you had anything else, and they sort of coined the concept of non-left bundle branch block, rather than calling it right bundle branch block or IVCD, we'll pull everything together, pool them, and its non-left bundle branch block didn't seem to improve. To try to look at this, whether it's a QRS duration, is a QRS morphology, we did this very large individual patient meta-analysis. Rather than looking at study results, we looked at 6 or 7 studies and about 3,000 patients, but had the patient data so we could treat them all as if they were individual patients. And what we were able to show was that QRS duration was a very potent predictor of responses. Here we can see these curves get nice and smooth because you have a lot of patients. It's fairly continuous, and where you tend to cross unity is around 120, 130 milliseconds, where we may be hurting patients. And interestingly, when we do a multivariate analysis of this from this database, you see that QRS morphology falls out. So left bundle branch block was not a predictor. It was all based on QRS duration, in part because patients with left bundle branch block have wider QRSs than right bundle branch block, suggesting that may have been why left bundle branch block do somewhat better. Other standard predictors of CRT, women tend to do better, patients with non-ischemic cardiomyopathy do better than ischemic cardiomyopathy, but QRS sort of ruled the day in this study. And clearly, QRS is important. a study was done called the ECHO CRT. It was a study of passionate echo folks looking at markers of desynchrony. We took patients with QRSs less than 130 milliseconds, and not only did it not work, but in fact they increased mortality. So implanting CRT in patients with narrow QRS is now a class 3 indication, something that should be avoided because we actually hurt patients by doing that. And probably the most recent data in the era of big data, so looking at a Medicare database, we were proud that we got 3,000 patients in our study, but then you get 25,000 when you start to look at these huge databases. And what they were able to show is probably both sides are right of this sort of discussion, that QRS duration is very important and QRS morphology is very important. Left bundles respond better than right bundles. Y QRSs respond better than not Y QRSs, but both of them are sort of important predictors. Well, the next thing I wanted to move on to, which has been really a focus of mine for the past few years, has been where to pace in CRT, the left ventricle. And for many, many years, where we paced was on the free wall, the lateral wall of the left ventricle. And this was based on surprisingly little data, small hemodynamic studies published 15 years ago, suggesting that you have a better hemodynamic response when you have your lead on the lateral wall rather than more anterior. And we did this hemodynamic study, again, a long time ago, which was intriguing to us because, again, relatively small number of patients, but we looked at different places to pace, and it didn't make a whole lot of difference where we were pacing, but any individual was very different. So this was pacing within a vein, so we'd move the catheter back and forth within a vein. And so, for instance, this patient number 10, had 100% doubling of their dPDT, the hemodynamic measure we use. And it didn't really make a whole lot of difference where we paced within that vein. They had this dramatic hemodynamic improvement, whereas patient number 9 didn't respond very much at all, no matter where we paced them. So the anatomy was less important, but there was something about that vein that made it a vein they were in that made it very useful. And when people started to look at some of these large studies, such as the companion study I already showed you, they saw the same thing. It really didn't make a difference where you pace, where you put the left ventricular lead, anterior, lateral, posterior. The responses were good, but they were similar everywhere. You couldn't really say, this is the right place to pace the left ventricle. And they looked at more endpoints because they were a bit skeptical, but 6-minute hall walk, quality of life, functional class. Again, everything was better than medical therapy, but it didn't really make a difference where you paced. And they came up with this somewhat nihilistic conclusion that pacing site was not important, which I think is wrong. Anatomy is probably not important. Anatomically guided therapy is not important. And the MADED CRT study looked at this as well, and essentially saw the same thing, that posterior, lateral, anterior didn't make any difference where you pace. But in their hands, pacing the apex of the left ventricle was bad. And I think others have shown that as well, that it's probably too close to the right ventricular lead, so you don't get much of a benefit there. So all of a sudden the idea came, rather than pacing the lateral wall, just don't pace the apex. But there are important aspects of where to pace. And one that came up is the idea of scar. In the more modern era, we tend to do more MRIs, we tend to look at scar. And it's become clear that pacing in an area of scar is not very useful. It's not going to contract, you can't recruit more fibers there. So those patients don't do well if you pace where there's scar. But I think more importantly, people have started looking mechanically, now using advanced echo techniques such as speckled tracking, showing that if you pace in an area of late mechanical activation, so if you pace where the heart's contracting last and pace there, you make that early mechanical contraction, so you resynchronize in some ways. Those patients appear to do better when you're pacing there. And in fact, there have been 2 randomized studies now performed, relatively small studies, about 200 patients, one called Target and one called Starter, where they do speckle tracking echo and place the leads at late mechanical contraction versus just placing the lead by standard anatomic criteria. And we're able to show, in fact, that in both of these studies, using guided therapy by mechanical contraction resulted in better outcomes in terms of remodeling or in terms of heart failure events in this group of patients. So it appeared to be interesting, important way to do things when we look at the results from these data. It's a little challenging. You need to obviously have a good echo lab that can do speckle tracking, and it's not always easy to try to correlate what you're seeing on an echo image to where you are on fluoroscopy and where you're placing leads. So we came up, started doing some work on a simpler electrical concept. In part, I'm a really bad echocardiographer, so I don't understand any of that stuff. So what we looked at was just electrical parameters. CRT is not magic. All it is a pacing therapy that changes where we pace, so it changes the electrical activation. And what we started measuring at our pacing site was a measure we coined the QLV. The Q being the beginning of QRS activation, which is when the heart starts to electrically, the ventricle be activated, and LV, the peak of our LV electrogram, which is where we'd be pacing. On the left is a patient who had a short QLV where we had our LV lead. On the right is a long QLV with the LV activation all the way at the end of the QRS complex. And the concept here, again, being relatively simple, that if we pace at a position of a long QLV, we're going to electrically resynchronize. Pacing there, we're going to make that early by pacing there, and therefore we'll get a more homogeneous activation of the left ventricle. So we've done a series of studies, an acute hemodynamic study showing that the QLV was a strong predictor of the hemodynamic response to CRT. We then took a large database from a different trial, but this was a study of over 800 patients, where again we're now dividing the QLV into quartiles, and we can see the longer the QLV, the greater the reverse remodeling in terms of change in left ventricular end systolic, end diastolic dimensions, ejection fraction, and even quality of life of patients. So a strong predictor of those patients. Mitral regurgitation, an important endpoint for CRT. Again, the longer the QLV, the greater the reduction in mitral regurgitation in these groups of patients. And I think importantly, when we do these typical forest plots to look at subsets of patients, if we look at, again, the responders clinically, we know that left bundle are better responders, wider QRS is better responders, non-ischemics are better responders, women are better responders. Yet when we look across all the well-known responders, it doesn't make a difference. If your QLV is long, you're going to respond, whether you're a woman or a man, whether you're left bundle or right bundle. So if you can find an area of late activation, you're going to get a response, at least a structural response to CRT. Well, more recently, we've simplified the concept a little bit. Rather than looking at QLV, we've looked at just the time between the right ventricle and left ventricle, the RV, LV, or the interventricular conduction delay. Part of this is not because we think it's a whole lot different physiologically, but because it's much simpler that devices can automatically measure this stuff, and you don't have to be measuring this on paper and other things. And we see essentially the same response. The longer the interventricular delay, quite nicely, the greater the remodeling that we see in these groups of patients, ejection fraction, quality of life, and everything else. And we've now finally applied this to a very large randomized trial called Pegasus of over 1,300 patients. And what we can show is if we look at clinical composite score, those patients with the longer interventricular conduction delay or RV-LV time have greater improvements and fewer patients worsened. And in fact, they have fewer heart failure hospitalization. So clearly, whether we use mechanical measures with spectral tracking or electrical measures such as QLV or RV-LV, placing leads and pacing at areas of late activation results in better outcomes in our patients. Well, one of the other aspects that people have worked on for many years has been the idea of optimizing our patients in terms of how we program the device. And the classic method that's been used has been echo again, where you look at mitral inflow, that you set your AV delays so that your E wave's greater than your A wave, your A wave's greater than your E wave, and if your AV delay is too long, they tend to fuse. If it's too short, it gets truncated. And there's been a lot of passion for years over this. I think very interestingly, what's really changed this field has been a study that came out of England. Darrell Francis is one of the great cynics in the field who doesn't believe anyone or anything. Turns out to be kind of good. And he did this study that I wouldn't, and probably very few people in this room would have the guts to do. And what he did was to take 30 of the experts in the United Kingdom who were like the gurus of echo and the gurus of doing echo optimization. And he went to these 30 experts and said, I have a group of patients. I'm going to give you 6 different AV delay settings, and here's their mitral inflow, A through F. I'm not going to tell you what the number is, but you have to tell me where should I set the device. Should I set it at the AV delay of C, D, E, or whatever? And if we look at one patient, patient number 1, doesn't look good. That didn't show up, but it was bouncing around a little bit, where it was. There wasn't tremendous consistency. But what Darrell did, which was very devious, is that there actually weren't 20 patients in his study. There were only 10 patients. And he gave everyone duplicates of the same exact traces. He put them in the packet that he sent them to do their analysis, but didn't tell them that patient 2 and patient 12 may be the same exact patient. So there were 10 sets of duplicates. So each observer was examining 10 different patients, but doing each of them twice. So what were the results when you look at these experts? Hopefully this one will come out. So patient 1 and patient 11 were actually the same patient, not only the same patient, but the same exact images. So the psychiatrists call this a Rorschach test. So this is how the experts in the same session graded themselves and graded things. So the conclusion, which is amazing, this is what they wrote in a peer-reviewed paper, that the operators disagreed with each other, they disagreed with themselves, they disagreed just as much with themselves as with others. It was not a failure of inexperienced readers, but a failure of the method. And their final conclusion of their paper in a circulation journal was they did not know what they did not know. So this was sort of one of the last, I think, hurrahs for doing echo optimization for CRT. And it led to a series of electrical-based measurements that could be automated and more reproducible, but still rather disappointing. There were 3 separate large trials, big numbers, 1,600 patients. The first was a Freedom study, and we can see here that 67.52, they had to go out to 2 scientific digits to show a difference between the two methods, so that if you turn this therapy on, you need 10,000 patients to show one more patient who may respond. So very disappointing result. So disappointing they never published this, which is sort of sad. I was involved in a second method that we thought was very useful, that it's going to be fusing activation, should work very well. And we showed hemodynamically it looked great and was a great predictor of patients. And then we did this prospective randomized study where we either just left patients out of the box at nominal settings, used the echo method I just told you about, or used this technique called smart delay. And a very disappointing result as well. Somewhat smaller study of about 700 patients, but while it may be slightly better, there was no statistically significant results. And a third study called adaptive CRT, again, was totally a bust. So we had 3 studies, all showed essentially nothing with a new technique, which again made everyone rather, negative feeling about using echo optimization at all. And what we're, at least I'm starting to think a little more about, is that we may not always be able to turn lemons into lemonade. And people were thinking that you take a non-responder and you tweak their AV delays and all of a sudden they're going to be a responder. And that doesn't seem to happen. A non-responder, maybe you could have a narrow QRS or SCAR or a bad lead position. However, we might be able to help patients who take a responder and make them a super responder or a better responder. And here's just a little bit of data in that regard. There are a couple of studies sort of pointing in that direction. This again is the QLV concept that I've already talked about, but now we're going to combine it with optimization techniques. So if we take patients based on their QLV, you've already seen the longer the QLV, the greater the remodeling response to CRT. But now if we break it out with either leave them out of the box settings or do an automated optimization, those patients who are going to respond because we're electrically resynchronizing in a long QLV are the patients who optimization is actually helping. So it may be that we can help patients, but you got to have your lead in the right position or be resynchronizing them. And completely independent, this adaptive CRT, which the original study did not look very promising. If you look at those patients who do get better responses because they have narrow, normal AV delays and wider left bundle branch blocks, when you turn on the algorithm there, they tend to improve. So if we take patients, again, destined to do better for a variety of different types of reasons, that may be the group of patients who are going to respond to our optimization. So just in summary, I think clearly CRT has been one of the more important advances in systolic heart failure in the last 25 years or so. Reverse remodeling is very important. Virtually everything good that comes out of CRT is associated with reverse remodeling, which again for heart failure doctors is not news. There's no drug, I don't think, still to this day that's been helpful that doesn't cause reverse remodeling, but structural changes are critical in this area. Electrical desynchrony is necessary, so patients with narrow QRS are harmed. Wider QRS patients on left bundles seem to respond. Physiologically guiding our lead placement, either with mechanical or electrical measures, will get us better responses. So simply just placing the lead outside of the apex is probably not good enough. And then electrical delay, which has been sort of the area that I've been more excited about because it's so simple to do. It identifies sites that have good outcomes and where AV delay may actually be helpful by optimizing it. Thank you.
Thank you for this great and comprehensive talk. We'll take questions from the audience.
I thought that was great. A few years ago, there was some interest in LV endocardial pacing as a means to do even better and perhaps reduce the non-responder rate. Do you think there's any future to that?
Yeah, so LV endocardial pacing is probably a more physiologic way to pace the heart because it gets activated from endocardial to epicardial, whereas through the coronary sinus, epicardial to endocardial, and you can sort of pace anywhere. And again, the acute hemodynamic studies clearly show benefit. The problem has been the technology. So if you take a lead and do a transeptal and put it across the mitral valve and stick it in the left ventricle, you get a problem of mitral regurgitation and you get a problem of thromboembolism. And studies have shown about a 5% risk of TIA or stroke, even in anticoagulated patients. So there are a couple of new technologies being developed. One of them is an ultrasound-based little pellet that you can put in the left ventricle that looks potentially promising, but it's probably not long-term viable because it's a very inefficient source and the pulse generators last about 18 months. But I think with our leadless technology for pacemakers in the right ventricle, people are working hard to try to develop left ventricular technology. And I think that will be an important component that years from now, we'll, rather than going into coronary sinus and looking for veins, we'll just be sticking small little leads into the endocardially in the left ventricle, but we're still a little bit away. But certainly looks promising.
Could you give us your thoughts on BiV pacing in patients with AV block after AV node ablation? Is it just for patients with low EF, or are there other better candidates?
Yeah, so we know that right ventricular pacing is bad, and the study that looked at doing this most recently was a study, BLOCK-HF, that looked at patients with an ejection fraction less than 50%, and BiV pacing was better than right ventricular pacing. There was another study called BioPace, which didn't restrict ejection fraction. They had mostly normal hearts that didn't show much of a benefit. And at least conceptually, I think that when you pace the right ventricle, your EF drops probably 5 or 10%. And if your EF's in the 40s, that may be enough to get you into trouble. If your EF's 60, it's probably not enough to get you into trouble. So we've sort of used the 50% cutoff rule for most of our patients, that if they're pacing all the time or in complete heart block, we need a pacemaker, we'll give them a biventricular device. What becomes more challenging is the young patients, the congenital heart block patients, the sarcoids, or some of those where you start to see heart block developing in patients either at birth or in their 20s or 30s. Biventricular pacing is attractive, that maybe will prevent late decline, but if we're talking about 30, 40 years, there's a lot of pulse generator changes and lead problems, and what to do with those patients with normal ventricles is less clear.
What about the patient? What about LV pacing versus BiV pacing in these situations?
Another good point. For complete heart block, LV pacing is not as good as biventricular pacing. Where LV pacing is potentially useful is patients with left bundle branch block, because those patients have activation down the right bundle so that you can pace the left ventricle and fuse it with right ventricular pacing and get a coordinated contraction. If you have complete heart block and you're just pacing the lateral wall of the left ventricle, you basically get synchrony in the opposite direction. The lateral wall contracts and then the septum contracts. So it doesn't appear to work as well. But for patients with intact AV conduction, and particularly left bundle branch block, LV pacing is certainly as good in some studies and better in other studies than biventricular pacing.
Do I need a microphone? If I yell? I won't be able to hear you. Oh, okay. Mike, that was lovely. I have a question for you. All the reasons that you do resynchronization therapy are sort of secondary reasons, aren't they? I mean, they're longer QRS complexes and whether or not some part of the LV is very late in activating and so forth. And my question is, it seems to miss the point of what the underlying issue is here, which seems to be myocardial dysfunction. Has anyone really looked at the differences in the super responders, for example, versus people who do not respond, trying to figure out what the difference in their myocardial function is? It's hard to do that, I recognize, but there are models for this, or is there some way to get to the bottom of this, which is not simply QRS complex, but what's going on in the myocardium?
Well, I think the super responders are the groups in which it actually is their activation pattern, because that's why it normalizes. And if you look at the predictors of a super responders, the predictors are women and non-ischemic cardiomyopathy and wide left bundle branch block. So the thought being that the only reason why they have a bad heart is because of this asynchronous activation, and if you correct the electrical problem, you correct the whole thing. Whereas if you have, previous myocardial infarction and scar, you're not going to make it normal because that scar is still going to be there. So that's sort of our, best sort of guess, and you rarely see, a truly normalization, 60% EF, unless someone has, falls into that sort of category.
Or myocarditis.
Yeah, well, those folks are going to resolve on their own. They probably shouldn't get a CRT. You probably ought to treat them medically beforehand. Yeah, if they have something reversible or temporary, transient.
Yeah, I mean, I think that's right, that there are patients who are labeled as cardiomyopathy, meaning that they have an underlying muscle disorder, who really have an underlying electrical disorder. One example would be patients who have right-sided PVCs, who undergo an ablation of the PVCs, and within several months their ventricle has recovered. The patients who I think respond best with left bundle morphology are those who have relatively normal-looking right ventricles. Their left ventricle is not dramatically dilated, it's moderately dilated. And those patients often, once the device goes in, they have a fairly quick improvement in their ejection fraction over a period of months. And those are the super responders. And the data that you show related to arrhythmia risk and survival, and coupling that with data that's come out of Europe about who necessarily with the dilated cardiomyopathy needs an ICD, do you think we'll get to the point at some point where we'll look at these patients and say, no, this patient just needs a CRT device, that ventricle is going to be 50% within the next couple of years, and their arrhythmic risk is low? Because defibrillators, as we know with all the recalls, have their associated problems.
Yeah, it's a good question. The Danish study you referred to is a whole different can of worms, but clearly there are probably patients who don't need defibrillator backup, and we've actually, I'm part of a consortium with Duke where we're applying to the NIH to do a study, which is sort of the first step of that way of taking patients who have CRT device who are at ERI, so the device needs to be changed. It's a bit backwards approach to it. But if they've been responders, so their EF is now greater than 45% and have never gotten therapy over their first device, can we just change them out to a CRT pacemaker? Which is what we do already in some of our elderly patients where they're now up in their mid-80s and quality of life is more important than quantity of life for some of them. And we do that, but we're proposing to at least do the first prospective study, because most of this stuff is retrospective, to say that it's safe to withhold defibrillators in patients who've improved. But I think clearly there are those groups of patients, and trying to identify them. Some have suggested do an MRI, and if they don't have scar, don't put in a defibrillator. Makes some sense, but we just don't have the prospective data, trial data.
Ask one last question.
Last question, yeah.
How do you decide when someone's too advanced for a CRT? Are there certain parameters you look at? You say, is the ventricle too dilated, or we really shouldn't be doing this? This patient's sort of too sick to move.
Yeah, the data on the class 4 heart failure and inotropic dependent patients are bad. I mean, usually the horse is out of the barn, and we've been reluctant to do those. The algorithms changed a little bit recently, and in recent years in the LVAD era. So, often the heart failure folks will say, we're going to give this patient an LVAD. Why don't we try a CRT first, to avoid committing them to, LVAD. And so we're probably back to doing more of those patients because, you know, avoiding the LVAD, where it used to be, you know, these patients are sick, we'll put them on a transplant list, but, you know, don't waste CRT on them. But clearly, if you look at QRS duration as a surrogate of left ventricular size, which it actually correlates with left ventricular size as it dilates, every curve, while I keep showing you QRS is a potent predictor, once you hit about 200 milliseconds, outcomes turn around, the curves turn over. And patients with QRSs, native QRSs of 220, 230, do really poorly with CRT, because, and those with, you know, ventricles above 8 centimeters do really poorly with CRT. And clearly, they're too far gone.
Thank you.
The preceding program is copyrighted by Emory University.